afternoon.
Good afternoon.
My name is Alvin Christine Uy and I'm from Cebu Institute of Medicine. Can I know your name and your date of birth, please?
My name is King Moon Han, and I was born on August 27, 1998.
Okay, so today, Munhan, I will be examining your heart and this will involve me looking from the end of the bed. And I will be listening and palpating your chest. Would that be okay?
Yes.
Alright, so before we proceed, do you feel any pain?
No.
Okay, and do you have any questions?
No, doctor.
Alright, so let's start.
Your examination of the heart will consist of inspection, palpation, and auscultation.
Okay, so now I'm gonna look at your chest.
Let's begin with inspection and palpation. To examine the heart, stand at the patient's right side and have the patient remain supine with the upper body raised to above 30 degrees. First, inspect the anterior chest, noting any heaves or lifts. None are observed here. Careful inspection may also reveal the location of the apical impulse when visible. Later in this examination, we will palpate to more clearly identify the apical impulse. Following the inspection, proceed with the general palpation of the chest wall. First, palpate for impulses using your finger pads. Hold them flat or obliquely on the body surface as you palpate at the right and left second interspaces along the left sternal border and in the apical area. Ventricular impulses may heave or lift your fingers. Then, check for thrills by pressing the ball of your hand firmly on the chest in these same locations. If subsequent auscultation reveals a leveled murmur, go back and check for thrills over that area again. Next, identify the apical impulse. The apical impulse represents the brief early pulsation of the left ventricle as it moves anteriorly during contraction and touches the chest wall. Note that in most examinations, the apical impulse is the point of maximal impulse or PMI. Some pathologic conditions, an enlarged right ventricle for example, may produce a pulsation that is more prominent than the apical impulse. Using the palmar surfaces of several fingers, then for finer assessments, your fingertips, followed by one finger, palpate to confirm the characteristics of the apical impulse. You will notice location, diameter, and amplitude. Identify the location of the apical impulse by the interspaces in which you feel it and by its distance in centimeters from the mid-sternal line. You can use a ruler to measure its distance. If you experience difficulty in locating the apical impulse, ask the patient to roll onto his left lateral side.
Can you tip over to your left, please?
That is, into the left lateral decubitus position. Palpate again using the palmar surfaces of several fingers. If you still cannot find the apical impulse, ask the patient to exhale fully and hold his breath for a few seconds.
Can you exhale fully and hold your breath for 3 seconds?
Measure the diameter of the impulse in centimeters. Feel for the amplitude of the apical impulse. It is usually small and feels like a gentle tap. However, obesity, a very muscular chest wall, or an increased anterior-posterior diameter of the chest may make the apical impulse undetectable. Next, feel for a right ventricular impulse at the lower left sternal border and in the epigastric or subxiphoid area. While keeping one finger in the third interspace, place additional fingertips in the fourth and fifth interspaces. If the patient's chest has an increased anterior-posterior diameter, palpate for the right ventricular impulse high in the epigastric area where it may be easier to feel.
Okay, so now, sir, I will be listening to your heart.
Let us now proceed to auscultation of heart sounds. When auscultating, it is important to know your stethoscope. The diaphragm is better for detecting higher pitched sounds such as S1 or S2, the murmurs of aortic and mitral regurgitation, and pericardial friction rubs. The bell is more sensitive to low pitched sounds such as S3 or S4 and the murmur of mitral stenosis. You will listen for S1 and S2 in each of the five listening areas. In the aortic area in the right second interspace close to the sternum, the pulmonic area in the left second interspace close to the sternum, the Erb's point in the left third interspace, and the tricuspid area in the left sternal border in the fourth interspace. And lastly, in the mitral area at the left fifth interspace medial to mid-clavicular line. The auscultation sequence will start with the diaphragm of the stethoscope and progress from the base of the heart, moving from the right second interspace to the left second interspace and down the left sternal border to the apex. Then, with the bell of the stethoscope, we will listen along the lower left sternal border in the left fourth and fifth interspaces. Then, we will listen at the apex. Adjust your stethoscope so that you'll be listening through the diaphragm. Begin listening in the aortic area at the right second interspace close to the sternum. Starting at the right second interspace helps orient you to the cardiac cycle. Note the cardiac rate and rhythm. Normally, the rate is 60 to 100 beats per minute and the rhythm is regular. Identify S1 and S2 and listen for extra heart sounds and murmurs. In the aortic area and also in the pulmonic area, S2 is usually louder than S1. Still listening in the aortic area, but focusing more in the pulmonic area, try to identify the inspiratory splitting of S2 into its two components. A2 is from the left-sided aortic valve closure. Its second component, P2, comes from right-sided pulmonic valve closure.
Please breathe deeply.
This physiological split of S2A and S2P normally occurs during inspiration. During expiration, however, these two components are fused into a single sound S2. Let's listen again.
Please breathe normally.
S2 usually diminishes in intensity while S1 becomes louder as you proceed down through the third interspace and into the tricuspid area. Listen at the apex. Here at the mitral area, S1 is usually louder than S2. Now, switch to the bell of the stethoscope. Listen next along the lower left sternal border and the left fourth and fifth interspaces. Then listen at the apex. To improve your ability to hear S3, S4, and the murmur of mitral stenosis, place the patient in the left lateral decubitus position.
Can you please tip over to your left, please?
This brings the left ventricle closer to the chest wall and makes low pitched sounds more audible. Then, recheck the position of the apical impulse and place the bell lightly over that location. If the patient had an audible S3, it would sound like this. Now notice how the third sound disappears when the bell is placed more firmly on the chest wall. Listen again with a light pressure. With firm pressure. And once again with light pressure. At this point, let's now go on to the attributes and grading of murmurs. Murmurs are differentiated from heart sounds by their longer duration. If you detect a heart murmur, you must learn to assess its timing, shape, location of maximal intensity, radiation, grade its intensity, and assess its pitch and quality. In listening for murmurs, palpating the carotid pulse as you listen can help you with timing. First, decide if you're hearing a systolic murmur falling between S1 and S2 and coinciding with a carotid upstroke, or a diastolic murmur falling between S2 and S1. Using the 6-point scale, murmurs can be graded. Grade 1 indicates a murmur that is very faint and heard only after the listener has tuned in. It may not be heard in all positions. A grade 2 murmur is quiet but heard immediately after placing the stethoscope on the chest. A grade 3 murmur is moderately loud, while grades 4, 5, and 6 are increasingly loud and accompanied by a palpable thrill. To better detect the more subtle diastolic murmurs of aortic regurgitation and mitral stenosis, you should routinely use two maneuvers. The first maneuver is performed with the patient sitting up and leaning forward.
Lean forward, big breath in, blow it out, hold it out.
Ask the patient to exhale completely and hold his breath out. Using the diaphragm of the stethoscope, listen at the left second interspace and down the left sternal border to the apex for the high-pitched, soft-blowing, decrescendo diastolic murmur of aortic regurgitation. Pause periodically to allow the patient to breathe. If the patient had this murmur, it would sound like this. The second maneuver for auscultating murmurs is to have the patient change to the lateral decubitus position. As demonstrated earlier, when auscultating heart sounds, this position enhances detection of the more subtle opening, snap, and diastolic rumble of mitral stenosis. A clear, well-organized clinical record employing language that is neutral, professional, and succinct is one of the most important adjuncts to patient care. To summarize, cardiac examination is consists of inspection, palpation, and auscultation. This ends my return demo. Thank you for your attention.